good morning. This is Reg Hay from Atlanta, Georgia. I'm a spine surgeon, and I'm hosting today part of our case debate series. This series is sponsored by NuVasive, and we'd like to thank our sponsors for providing for this educational venue. Our guests today include two good friends of mine, Rick Sasso, who is an orthopedic surgeon in Indianapolis, Indiana, and Chris Shaffrey, who has the dubious distinction of being both certified in orthopedics and neurosurgery. So today's debate is looking at anterior cervical surgery, specifically today anterior plates, and why change. And the debate aspect of this is, for years, I've heard Rick Sasso say a plate's a plate's a plate. It doesn't really matter. They're all good now, especially in anterior cervical surgery. And I've heard Chris Shaffrey talk about deformity plates and thicknesses and stiffness and things like that. So the three of us today are three old guys. We've been around since plating started in the United States in the late and mid-1980s. And we're just going to talk a little bit about the evolution of plates and where we are today. Do plates matter? Do they not matter? And where we're going in the future. So Rick, let's start with you. When was the first time and type of anterior cervical fixation you did?
So first anterior cervical plate that I was involved in, Reg, was in the mid to late 80s, probably 86 or 87, and it was an Orozco plate, which is, you will remember, was one of the first plates made for the anterior cervical spine, but basically the technology was that of a forearm plate. The screws did not lock to the plate, so therefore we had to get bicortical purchase into the vertebral body. We had to engage the posterior vertebral body wall. We had to drill through it, tap through it, and engage one or two threads through it. And that was tough. That was hard.
So my first plate was in the fall of 1988. Chris, were you still in training at Virginia at that time?
Yes. We also, very similar to Rick, probably in the mid-80s, 84, 85, 86 timeframe, had used the cast bar plate, was our initial plate, with the same concerns that it was a relatively technically demanding situation, because if you did not get bicortical screw purchase, there was a real noticeable risk of the screws backing out. And if you that plate had both holes for screws and slots. And one of the things that happened, that particularly if you did not get bicortical purchase in the slotted screw areas, the screws would back out and could potentially impinge upon the esophagus or create other problems. If you put them through the holes that were in the plate, that the screws frequently broke, or occasionally the plate itself would break at that area. So plating isn't what it is today. Plating was thought to be something that was an adjunct, but there was some real question whether it was a favorable adjunct. So I think a lot of things that subsequently occurred in reaction to the shortcomings of these initial plates.
Chris, I always thought they were trauma plates. When I first started doing anterior cervical surgery, most neurosurgeons were not even doing a fusion, just a discectomy, and the spine would collapse and sometimes had pseudoarthrosis and foraminal stenosis. And the orthopedists were fusing, and then we were using autograft, and then later in the late 80s, allograft, and putting everybody in a brace for 10 or 12 weeks. The first cast bar I did was actually a beautiful young woman broke her neck in horse country, and John Jane, the chairman of Virginia, put her in a halo. She came to see me because she had collapsed kyphosed and had myelopathy from a C5 compression fracture. So I did a allograft fibula and a bicortical cast bar plate. And I think back then for neurosurgeons, it was mostly trauma. That when we heard people started plating for discectomies, we thought that was heresy. And actually, I had published in Spine looking at our first allograft without plates and our first allograft with plates. And as from Columbia published, we had higher fusion rates. But as you said, there were problems. Wolf Caspar, Todd Vinstronellis, and I had put on long plates. They would subside, they would fuse, but the plates would impinge on the levels above and below and get adjacent level disease that Dan Rue has talked about. But I really think plating changed when the Synthes CSLP, or the locking plate, came out. Rick, you want to talk about that?
Sure. First CSLP plate I put in was in 1991 when I was a fellow. It just came to the U.S. then, and it really changed our ability and made this operation more reliable because we did not have to get bicortical purchase. The screws locked to the plate, so we did not have to drill and tap through the posterior vertebral body. There were some problems with the initial CSLP though. The initial screws were fenestrated. The thought was bone would grow through the screws, and they thought that was a good thing. The problem is those screws, because of the holes in them, were weaker, and so we had a very high failure rate, breakage of the screws themselves, and so those were subsequently changed over time.
So, Rick, I had the same problems with the fenestrated plates. What was nice is the plates, or the screws, frankly, did not have to be bicortical. They were unicortical screws. The angles were somewhat predetermined, which was good because it made it simple. It was bad because it decreased the variability. But Chris, I had some plate breakages that were sent to me. Did you encounter that problem?
Yes. You know, what's happening was the advantage of the fenestrated screws was I do think that there were, in fact, cases where there was actually bone ingrowth. The screws not only fenestrated, but there was a sort of a surface fixture to them that at least theoretically promoted bone ingrowth. So there were cases where that occurred, particularly in younger patients. But if the graft subsided, then something had to happen. And usually the plate would break, and usually where it would break is in the screws. There were sort of some intermediary screws, and particularly for more than one level fusions, the plate would frequently break through those intermediate screw holes. And because of that, I think that led to, for a number of the companies, to develop thicker and more robust plates that reduced the risk of plate breakage and used a different mechanism of screw retainment that allowed the development of screws which could have some movement, the first sort of variable angle screws. So the combination of the variable angle screws led to the ability of the screws to move a little bit if any subsidence occurred, and then the plates themselves were thicker, and it got rid certainly reduced the risk of plate breakage. But these plates were markedly thicker than what had been previously used with either the Caspar plate or even the CSLP plate.
You know, I think what you're describing is with the Synthes plate, we got unicortical screws, fixed angle screws, screws that did not back out, but it was so rigid it broke. So the Orion plate, I think, became the leader then, and it was a tank. It was over-engineered. It took the advantages of unilateral or unicortical screws or bicortical screws. It had a locking cap that made it very rigid. It had tapered screws that didn't break because the stress riser was not so great at the screw plate interface. But I think it was a little bit rigid, and there were concerns about graft shielding, stress shielding. So Volker Sontag and Steve Papadopoulos and I worked with a J&J company, Codman. And Chris, you've later designed with the same concept where we had a cam where we had unicortical variable angle screws that did not back out, but they were only variable angle. And the point was that the graft would see some stress. Your thoughts about that, guys?
Well, sure, Reg. That was a great advantage. We were seeing high rates of failure with the screws that were rigidly locked to the plates because they, as you mentioned, they unloaded the graft, and the graft requires loading for it to heal appropriately. And so the ability to load the graft and allow the screw angle to change within the plate was very, it was good. It was a good thing. The other thing that was good is it allowed us to use shorter plates because we could hyperangulate the screw through the plate, and that would decrease this incidence of the plate driving up into the disc space above, which we saw unfortunately fairly common as the graft would load, settle, and the plate would drive cephalad. So the ability to hyperangulate the screws through, especially the cephalad plate hole, was important.
Rick, I think that that point cannot be hammered home enough, is I think we've all gone to very short plates, and we're inserting the screw at the intersection of the anterior face and the cortical end plate, which is the strongest aspect of the body. There's less infringement on the adjacent level, and if we have to do the adjacent level, we don't have to take the plate off typically. You think that's correct, Chris, or are you still putting on relatively medium-sized plates in length?
No, I think that I think most of us have moved towards using as short a plate as we realistically can use, with generally more angulation of the cephalad screws. And the advantage, as you said, is you develop adjacent problem, you can put a plate next to it without removing the original plate. The other advantage is I think there is enough literature that clearly shows that as the cephalad aspect of the plate approaches the next disc space, that it can lead to adjacent segment degeneration. So I think that there's several theoretical and probably practical reasons to use short plates. I think the one thing that you had mentioned earlier, I think there's always a little bit of a balance that if there's too much potential movement through an area, will a plate still be the best one to use in cases of trauma where there is some substantial instability that is present? You know, are variable angle screws better? And I know there's some literature that goes in both directions. At least biomechanically, fixed screws are at least biomechanically more sound in trauma cases. I think there's some cases of deformity where you don't want the whole spine to collapse down into its original position. So I think that we've learned over time that there's roles for fixed screws, there's roles for variable screws, and there is certainly roles for graft loading that are all important considerations.
Well, Chris, that leads in well. That's what we were thinking at the time. So again, both Chris, Steve, and I worked on the Atlantis plate, which actually gave the surgeon all those options. So instead of having to bend the plate was pre-bent to a normal lordosis, and the surgeon had the ability to choose whether the screws were all fixed, like an Orion or CSLP, whether the screws were uni or bicortical, whether the screws were all variable, or for the first time, we could have a hybrid construct, for instance, where we would put rigid screws on the bottom and variable screws on top with a thick plate. And I think we continue with the evolution of that, and that became kind of the workhorse of most of us. And it works great, but over the years, I've seen some subtleties, Rick, whether we do a 1-level plate or a 5-level plate, or whether we are preserving lordosis or restoring lordosis. Have you noticed similar issues as we gain more sophistication?
Yeah, and I think you hit the nail on the head, Reg, that there are differences when we are reconstructing a 1-level ACDF or whether we're doing a 5-level construct for deformity correction. And the problem is, I think in the past, we've over-engineered our plates for the long constructs so that we didn't see failures in them. The problem is they became very, very thick. They became really fat plates. And what we're finding out now is that complications such as dysphagia, probably the most common problem that we see after ACDFs. And so we know that when we use thick plates, we have a higher incidence of dysphagia. And so trying to decrease the profile of these plates and make them very smooth, make them much better for living under the esophagus is important. And I think it is important that we consider the environment that we're placing our plate.
So Rick, is there a place for a ultra thin plate? I mean, we certainly have thick plates or deformity plates, which I'll ask Chris about in a second. And we have thin plates on the market now. Sometimes they bend out. So is there a role for an ultra thin plate? And if so, what is the role and what's not the role of the ultra thin plate?
Absolutely, I think there's a role, and the role is in 1 and 2 level ACDF reconstructions. And I think when you look across the board, that's probably one of the most common indications for an anterior cervical plate are these 1 and 2 level constructs. And it is important that we make this plate as thin as possible and use these ultra thin plates. I think they absolutely help in decreasing the incidence of dysphagia. The problem, though, is we still need those other important variables such as hyperangulation. Once you make a ultra thin plate, there becomes issues with the ability to hyperangulate a screw through a plate. So there has to be some engineering considerations for that. But yes, across the board, that's probably one of the most common indications for an anterior cervical plate are these 1 and 2 level constructs. And it is important that we make this plate as thin as possible and use these ultra thin plates. I think they absolutely help in decreasing the incidence of dysphagia. The problem, though, is we still need those other important variables such as hyperangulation. Once you make a ultra thin plate, there becomes issues with the ability to hyperangulate a screw through a plate. So there has to be some engineering considerations for that. But yes, there absolutely is an indication for a hyper thin plate.
I was a believer that that a lot of the morbidity associated with major spine reconstruction occurred through the posterior aspect of the procedure. And although you had some issues regarding dysphagia and some other things from the anterior portion, I feel that the majority of people that had complaints after a major reconstruction were related to the posterior surgery. So because of that, I had a philosophy that if I felt that through a combination of an appropriately crafted operation with an appropriate plate and appropriate inner body spacers, that you could get by in a certain number of cases without doing the posterior portion. So I started doing that when I was using cortical cancellous spacers, that my decompression became wide enough and I was comfortable enough resecting uncovertebral joint spurs and other areas that I could typically put at my bottom level 2 of the cortical cancellous spacers in a single disc space. And I would do this more typically at the bottom levels, either 5, 6, 6, 7, 7, 1, where I would assess on the MRI where the vertebral arteries were. I would drill out laterally enough that I could put 2 spacers in a single location. And my belief was that by putting a broad area of coverage and using a somewhat lordotic spacer and releasing the area appropriately, that through a plate that could go and allow with essentially bicortical screw fixation and the use of fixed screws, particularly at the bottom, to have a rigid enough construct that could spare the posterior surgery. Now, that led to the development of NuVasive's Archon reconstruction plate, and that plate had, at the cephalad and caudad levels, 3 holes. And we biomechanically tested that plate, and the plate with 3 holes, due to the width and thickness of the plate and the ability to retain the screws, was biomechanically as sound as an anterior and posterior operation for biomechanical testing. Now, the testing didn't include repetitive testing. It's not like they took that out to 10,000 cycles, but for the usual testing that was done that showed that that type of a construct was a good one. The trouble was, as I moved towards sparing a lot of posterior neck pain, other complications like a little bit higher infection rate with posterior cervical cases, what I found was my dysphagia rates became higher and higher, and I think in part due to doing longer surgeries in the front, but also due to that plate being very thick. And because of that, that has led me to have the desire. I think that the philosophy of trying to spare posterior surgery is good, but I think that when you have a very thick plate, that has its own set of inherent problems, and that what I was doing was changing one complication for another. And that's why, my zeal for having a plate that allows us to do deformity correction from the front, but be able and have it stiff enough to allow that deformity correction, but also thin enough that it reduces the dysphagia that you can get from a very thick plate.
So I think we're all driving in the same direction, right? And so there is the thinness aspect. We want the thinnest plate possible. And Chris, what you're talking about is we keep saying thick, but what we really want is stiff. That's what our goal is. And so when we do deformities, we want a very stiff plate. If you look at your PowerPoint, this is a patient of mine that I chose a plate, which is a stiff plate. And I was correcting a cervical kyphosis, and I corrected it tremendously. However, as I applied the forces and put the screws in sequentially, I thought I was bringing my spine into alignment. And I did somewhat, but if you look at this, I actually bent out the plate, and that's a thick plate. So what's happened to me is I started using the thinner plates that are now on the market. I found that for 1 and 2 and 3 levels, they were okay. They preserve lordosis well, but they bent out. But here's what happened again. I actually started looking at my x-rays more. And I always thought that I was restoring lordosis with my thick plates. And actually, I think I was fooling myself as I saw the spine come with the plate. What I was really doing is I was bending out the plate, Chris. And you and I have talked about that. So I think as we start correcting more and more things anteriorly, as we are in the lumbar spine, where we have tremendous correction forces, I think we're going to need a stiffer and stiffer plate with the ability to have stiff screws or variable screws. So what I think I hear, Rick, is when we want to preserve lordosis, not restore it, in 1 and 2 levels, we want an ultra-thin plate. And when we want to do a deformity, we need a longer, stiffer plate. And if we have those two extremes, Rick, is there something in the middle that we can work on that's maybe a 3 or 4 level plate that allows you to have more stiffness than the ultra thin and also allows you to have a hybrid construct if you wish?
Sure, I think that is important, and also have the ability to utilize either fixed screws or variable screws, and depending upon whatever the deformity or fracture or tumor that we're taking care of, that ability to change with as thin a plate as possible, but still as stiff a plate that will get the job done is very important.
So I think what I'm hearing you guys say, there's kind of, if you differentiate and segment our needs as we gain more sophistication, if it's a 1 or 2 level lordosis preservation, we can use a very ultra thin plate with variable screws. In the middle ground, we can have a medium thinness plate, just a thin plate with the ability to place fixed or variable or hybrid. And then in a longer deformity, we need a stiffer plate. Is that what I'm hearing?
Absolutely.
And I agree with that. The trouble is that I think that the plate thickness for a 1-level case probably has less impact on the esophagus and swallowing than having a plate for multiple levels. And we see this in some cases of dish and whatnot. Most people, if they have one spur at one level, somehow their esophagus can compensate for it. But those patients with dish that have spurs at multiple levels up and down the spine are the ones, in my experience, who have far greater incidence of dysphagia. So this plate thickness becomes an issue as you add the levels that you're doing. And so the holy grail would be to have the same kind of ultra thin plate to be able to find a way, whether it's plate geometry or plate materials or whatever, that eventually we could have an ultra thin plate that we could use for multiple levels to allow overcome the shortcoming that I saw. The Archon plate, I never had the reconstruction plate with the 3 holes. I never had a biomechanical failure. No non-unions. The plate was super stiff, and I was able to pull the spine and not have the bending out. But the problem was that I had an unacceptable rate of dysphagia. And in part it was because the plate is wider, so I probably am pulling on the esophagus more. But I think the plate thickness, when you do multiple levels, and particularly if you go up into the upper cervical spine, C2 and C3, I think that is associated with a higher rate of problems if you have a prominent plate. So I think that as we move forward, balancing all these factors of plate thickness, construct versatility, the ability to restore lordotic alignment, and to do it in a way that gives us this versatility, I think is really going to be important moving forward.
Well, Rick, as we've discussed before, as we summarize this, I think we're learning more and more that when we restore lordosis in the cervical spine, it's doing an excellent oncovertebral release, and it's putting in implants, our spacers that are hyperlordotic with a wide footprint. And I think we're learning that there's different materials for that. We're also learning that in the posterior cervical spine, just like the posterior thoracolumbar sacral spine, there's differences of rod diameter, rod stiffness. There's differences if we're going to maintain alignment or correct alignment. And I do believe as we go into our next 2 series, as we talk about interbody spacers and posterior longitudinal members, we're going to tie all this together with our current thought processes that have evolved over the last 30 to 35 years. Any closing comments, Rick and Chris?
Well, I think you're absolutely right, Reg. We need to think of this all together. We need to think about what we're putting in the interbody space or the corpectomy defect, and we need to think about our posterior instrumentation, because we can't think of anterior by itself or posterior by itself. Many times we need to think about this together, and I'm very excited about the next few sessions talking about what we've learned from the past and what we need for the future.
Chris?
I don't think I can add to what Rick had said. I think that There are exciting times, and I think the combination of our gradual knowledge, mostly gained through shortcomings of existing technology, and I think the ability with biomechanics, biomaterials, and really talented engineers to come up with something that meets all the different requirements is important. I think that one of the mistakes that we have made previously is that we have all wanted to have kind of one universal implant that does absolutely everything. It's the best one for one level cases. It's the best one to treat somebody with a horrible cervical deformity. It's the best one to treat trauma. It's the best one to treat a reconstruction after a tumor has destroyed much of the spine. And I think that that one implant's never going to do that. I think that that for many of the different things that we would like to do, it results in a compromise for what would be ideal for a specific task. And I think, as Rick has so clearly stated, I think that we have the ability to segment different important procedures to have something that's ideal. I think the one implant fits all model has been a shortcoming, and everything has resulted in a compromise. And we can now do a patient-specific implant. We're talking about personalized medicine. This is the ultimate example of doing personalized medicine, the exact right implant for the exact right condition. And I think moving forward, that is truly exciting.
Gentlemen, I'd like to thank you once again. Chris, I think your closing comments about personalization of medicine and personalized implants for each surgeon to take his or her abilities with the patient's needs and to customize them, I think that's absolutely key. Obviously, we talked about the plate today. It's more than just the plate. It's the patient positioning. It's the type of exposure. It's a type of interbody implant, and it's the potential need to go posterior. So I really look forward in future series to talk about the other issues, with our next series being upon interbody spacers, materials, widths, shapes, and sizes. Also like to thank NuVasive for allowing us to have this conversation in this debate series so we can enhance the care of our patients. Thank you once again.